Audio recording for this meeting has begun. You have been muted. Your microphone has been turned on.
Good afternoon, everyone. My name is Leandra Lacey, and I'm the Capacity Building Manager at the National Coalition of STD Directors, or NCSD. I'm joined today by my co-host, Elizabeth Rubush, the Director of STD, HIV, and Viral Hepatitis at the Association of State and Territorial Health Officials, or ASTO, and Rebecca Horowitz, Senior Analyst at the National Association of County and City Health Officials, or NACHO. We would like to welcome you all to engaging with tribal communities in responding to STDs, an update on the Indian Health Services STD Surveillance Report and how health departments can collaborate with tribal organizations. So we're so excited. This is such a great topic, and we're going to jump right in today. So this is just a reminder that this webinar is being recorded. The recording and slides will be made available to all of those who registered, and will also be sent out to ASTO, NACHO, and NCSD's respective networks. You can also download the slides right now if you'd like in the files box on the right-hand side of your screen. Additionally, I'll ask that if you are not speaking, your phone line or computer speaker is muted to prevent any background noise during the presentation. I believe that I just muted everyone, so hopefully that works. We'll see. But if it did not, I just ask that you mute your phone line to prevent any background issues. And if you have questions or need technical help during the call, you can utilize the chat function in the bottom right-hand corner of your screen, or private message me or any one of my other hosts. All questions will be addressed at the end, but we'll definitely keep a queue and read them aloud at the end, so please put them in the chat box as they come up. So as far as the agenda today, I'll go over the objectives for the webinar, and then we'll have Dr. Andria Apostolou at the Indian Health Service speak. We'll then have Amanda Gill from the South Dakota Department of Health. And then last but not least, we'll have PJ Beaudry from the Great Plains Tribal Epidemiology Center, and then we'll have the Q&A portion at the end where we'll take everyone's questions. So as you can see from this slide here, this webinar today aims to provide an overview of national STD trends among American Indian/Alaska Native populations, including considerations for state and local health agency program planning. We'll highlight some activities and lessons learned from the South Dakota Department of Health STD program partnership with tribal communities there, and then also describe the role of the TECs and specific experiences from the Great Plains TEC, and collaborating with health agencies and other local partners to address STD rates within tribal communities. So we're hoping that you'll glean a lot of great information that you can take back to your jurisdictions and use to engage with tribal communities. So I will hand it off for the introduction of our first speaker.
Thank you. Thanks for joining, everyone. And we, as the National Association of County and City Health Officials, are very happy to be hosting this webinar with ASTO and NCSD to share this information on an often overlooked population and consider how STD rates can be tackled by working with the community. For the first part, I'd like to introduce Dr. Andria Apostolou, who's the Indian Health Service National STD Program Lead and a Senior Epidemiologist with the IHS Division of Epidemiology and Disease Prevention. She's a graduate of the Centers for Disease Control and Prevention's Epidemic Intelligence Service and the CDC's Health System Integration Program. She has a PhD in molecular medicine from the University of Maryland and an MPH in epidemiologic and biostatistical methods for public health and clinical research from the Johns Hopkins Bloomberg School of Public Health.
Thank you so much for the introduction. I would also like to extend a big thank you to ASTO and CSC and NACHO for hosting this webinar, and I'm excited to be co-presenting today with Amanda and PJ. Thank you for those that joined us today to bring awareness to STDs impacting American Indian Alaska Native communities, especially this month, which is STD Awareness Month. So before I present the information on our STD report, I just wanted to provide some overview of the Indian Health Service for those of you that are not familiar with IHS. So IHS is an agency within the Department of Health and Human Services, and is responsible for providing health services to 2.2 million American Indian Alaska Natives that belong in the 573 federally recognized tribes in 37 states. There are 45 IHS and tribally operated hospitals. 5 of them are critical access, and there's over 550 health centers, Alaska Village clinics, and health stations around the country. And on the map of the left, you'll see the 12 IHS administrative areas that we operate under. So this map is from the U.S. Census, actually, and it just shows the geography and population density for AIN people in the U.S. So as you can imagine, many AIN people live near or on reservation lands, but many AIN people live outside these areas, particularly in big urban centers like New York and LA. So I encourage all of you that are coming from state, local health departments to get to know these populations in your own jurisdictions. So this is the website for the National STD program at IHS. So we sit under the Division of Epidemiology and Disease Prevention. So we have a main focus around data and epidemiology. But we are within the Office of Public Health Support here at headquarters, and we are located in Rockville, Maryland, just outside the DC area. So you'll see on the right side of your screen, I also put a circle around our STD listserv. So for those that are interested to receive information around trainings, grants, and other opportunities to work with tribal communities around STD prevention, I will encourage you to click on the link. I think you just request your name and email address, and we send messages once or twice a month through this listserv. Here are some of our program goals. Obviously, a main goal is to raise awareness of STDs among AIN as a high priority issue, but we also like to build partnerships internally within IHS with our clinics, but also externally with federal, tribal, local, and state public health officials, and of course with advocacy organizations such as NACHO, ASTO, and CST. And we also support surveillance and, whenever possible, outbreak response efforts. We also do trainings for medical providers and public health professionals. So I'll now switch a little bit to the main topic of my presentation. So as many of you know, each year in the U.S. it is estimated that about 20 million new cases of STDs occur. And unfortunately, AIN communities bear a disproportionate burden, with chlamydia and gonorrhea rates among AIN reported to be about 4 times those than whites. And then also syphilis and HIV also have the proportionally higher burden among AINs. Since STDs can be asymptomatic, it is important to diagnose early and treat appropriately both the patient and the context, and to prevent other sequelae such as pelvic inflammatory disease and infertility. And nationally, among all races, half of all STDs occur in those under 25, so the young and adolescents are really impacted. So the IHS National STD Program released in late 2018 the Indian Health Surveillance Report, Sexually Transmitted Diseases 2015. And this report represents a unique collaboration between IHS and CDC. We had previous versions of this report going back to 2006, but for today's presentation, the main focus will be the 2015 report, and I have included the link at the bottom of this slide if you want to access the full report. So this report represents statistics and trends for STDs, chlamydia, gonorrhea, and primary and secondary syphilis among AIN between 2011 and 2015. And it consists of two main components. The first portion of the report provides a national STD profile, which contains figures and text that provide overview nationally of STDs and also of AIN in the U.S. And then the second part presents rates and trends for the 12 IHS administrative areas that I showed in the map in the beginning. So I would like to discuss a little bit the methodology for the report, especially for those of you that are coming from state and local health departments. The data that we include in this report are obtained from CDC's National Notifiable Disease Surveillance System, which obviously receives the reports from all of you from the 50 states and Washington, D.C. And the variables that we included were case age, self-reported race and ethnicity, and county of residence. And the reports that are received for three conditions, again, chlamydia, gonorrhea, and primary and secondary syphilis. We use the denominator to calculate truth rates from the U.S. Census, annual population estimates, and also we present truth rates in the report by race and age groups in addition to the overall truth rates. And I'm not going to go really over racial misidentification and in this presentation, but again, for those of you that are coming from state and local health departments, it is really critical for us that a lot of this information, particularly around race ethnicity information, is captured as closely as possible, because that's the data we rely on to build this report. So I've just put a call out there for those of you that are actually collecting a lot of information to put as much effort as possible to correctly identify individuals so we can actually monitor these trends more accurately. So for the national STD profile, the race categories must comply with the Office of Management and Budget, OMB 1997 race ethnicity classification. So for this report, for any trend analysis stickers and tables that we included, a state must be compliant for all 5 years to be part of the trend. And for the national part of the report, again, AIN Hispanics are reported separately from AIN non-Hispanics, and multi-race cases and rates are reported separately. This aligns with the national CDC STD report. For the second part of the report, where we zoom in to the IHS area STD profiles, we define as cases all AINs independent of Hispanic ethnicity, and the multi-race cases and rates are not included in the AIN categories. Cases are reported only for the counties where IHS provides services, and therefore we have 15 counties that are shared between IHS areas, and for those counties, chlamydia and gonorrhea cases were assigned to the one IHS area based on the IHS calculated ratios. But for primary and secondary syphilis, since the case number are lower, the cases were assigned to the appropriate IHS area based on an assessment by state STD coordinators using the case's home address. So we did not receive the addresses at IHS. We reached back to state STD coordinators in those states and worked with them to closely identify which IHS area was the appropriate to use for that syphilis case. I will now show some of the results for these conditions. First, for chlamydia at the national level. So nationally, chlamydia rates remain relatively constant between 2011 and 2015. We had a slight increase in between 2014 and 2015. And then when we look at these rates by race and ethnicity, the second line down from the top is AIN. So we see that AIN have consistently the second highest rate of chlamydia among all other races and ethnicities for the entire. And AIN also had higher rates than the U.S. total for 2011 to 2015. There was a slight increase in between 2011 and 2012, and then a slight decrease since then. This pattern is very similar between males and females, with females having higher rates than males consistently through 2011 to 2015. And then when we look at this information by age distribution, on the right side of your screen, you'll see females, particularly those between 15 and 24, are the mostly impacted, which aligns with the national estimate for all races and ethnicities. So switching now to gonorrhea. So nationally, gonorrhea levels have remained steady between 2011 and 2013. We saw an increase between 2013 and 2014, and even a steeper increase between 2014 and 2015. And when we look again the rates by race ethnicity, again the second line from the top, AIN have again consistently the second highest rate of gonorrhea among other races and ethnicities for the entire period. And sorry, going back. And again, comparing to the U.S. total, gonorrhea rates among AIN were higher than the U.S. total for the entire period, and they have been increasing steadily since 2011 and almost double in this time frame that we analyzed in the report. The same pattern is shown between males and females in terms of increases, but you'll notice that AIN females still have higher rates than AIN males for the entire period, similar to chlamydia. This is actually quite different than what we see nationally, where males have higher rates of gonorrhea compared to females. So it's a little bit different pattern, epidemiological pattern that we see among AIN communities. And again, by age distribution, you'll see on the right side of your screen, the AIN females between 20 and 29 are mostly impacted. So it's shifting a little bit older than the chlamydia rates, and a little bit different pattern than what we see nationally, which is 15 to 24 again. And finally, I just want to talk about primary secondary syphilis at the national level. We have seen increasing rates since 2011, even steeper incline in 2014 to 2015. And then when we look at by race ethnicity, we'll see 2015 we had a drop for AIN. So AIN had the fourth highest rate among all races and ethnicities. Rates increased between 2012 and 2014, and we did see that drop that I just explained in 2015. And unfortunately, though, since then, many of you might be aware of, we have had many outbreaks among tribal communities. Unfortunately, that drop in 2015 was not sustained. So we're seeing increases since then. Similar pattern between males and females. This time, the epidemiological profile changes. Males have higher rates than females, and you'll see by age distribution on the left side of your screen, males have a higher rate, particularly those between 20 and 34. But interestingly enough, we see cases along the lifespan and in almost age group. So I just want to talk briefly about the national and area STD profile, the second part of our report. First, the national STD profile. So here you'll see a map of the geography that we have used to analyze our data. So in 2015, there were 35 states that were included, with 641 counties in the 12 IHS areas. So for chlamydia first, between 2011 and 2015, we had about 61,000 chlamydia cases that were reported among AIN living in IHS service areas. The majority, about 80%, were among women, and the chlamydia rate increased from 2011 to 2012 and then declined between 2013 and 2015. 9 of the 11 IHS areas that had trend data experienced declines in their overall chlamydia rates from 2014 to 2015, except Albuquerque, Navajo, and Phoenix. And then in 2015, the total rate for IHS areas was 1.4 times higher than the overall U.S. rate, with a disparity affecting, again, AIN females who had 1.7 times higher rates compared to the U.S. females. AIN between 15 and 29, AIN females between 15 and 29 have the highest rate. And in this graph, we actually ranked the IHS areas by their rate for chlamydia and the number of cases. So you will see for chlamydia, the highest rate was in Alaska and the lowest was in California. And Alaska also had the highest number of cases. For gonorrhea, We had about 12,000 cases reported among AIN living in IHS service areas. The majority, 64%, were among women, and rates increased every year between 2011 and 2015, with 10 out of 11 IHS areas that had trend data experiencing increases in the overall gonorrhea rates between 2011 and 2015. In 2015, the total rate was 1.5 times higher than the U.S. Overall rate, with a disparity affecting, again, AIN females who had 2.1 times higher rates compared to U.S. females. And females also had higher rates than males, as I explained earlier, in all IHS areas, except we're seeing a change in trends in Albuquerque and California areas where now males have higher rates than females. And again, the same age groups had the highest rates. So in terms of ranking, we see that the highest rate was in Great Plains, and the lowest rate was again in California. Great Plains area also had the highest number of cases. Then finally, for syphilis, between 2011 and 2015, we had 390 primary and secondary syphilis cases that were reported among AIN residing in IHS areas. And unlike chlamydia and gonorrhea, most cases were among males. We had an increase overall between 2012 and 2014, and then we saw the decline in 2015. The total rate for all IHS areas was 40% lower than the overall U.S. rate in 2015, but as I said earlier, unfortunately, that decrease was not sustained. And then males, particularly those in the 30 to 34 age group, are the ones mostly impacted. Then in terms of ranking, kind of a little bit of a different profile. We see Tucson had the highest rate. The lowest rate was in Alaska. Alaska actually did not report any syphilis cases in 2015. And the highest number of cases were actually in the Phoenix area. And I do not have tables and figures to show you for the IHS area specific STD profile, but I just wanted to mention briefly that for each of the 12 IHS areas in the report, there's a section for each of the conditions. So we have figures representing information on the specific area rates compared to IHS and compared to U.S. total for 2011 to 2015. And then we also have figures representing rates by sex, and then also by sex and age. Again, these are for each of the IHS areas, and because of time limitations for today's presentation, I'm not sharing any of the results, but I encourage all of you to take a look at the data, and particularly for your area, for your state, and kind of look at the trends for your neighboring jurisdictions as well. So to summarize, the report shows continuing trend of a nationwide increase in STDs. It also highlights disparities among AIN with national data indicating that the 2015 AIN had the second highest rates for chlamydia and gonorrhea and the fourth highest rates for syphilis among all racial and ethnic groups. And we saw some regional differences with gonorrhea rates increasing nationally among AIN. And unfortunately, the youth and women, particularly women of reproductive age, are impacted by STDs in Indian country. I do not have a lot of time to go over all of this information, but we have been taking some recent initiatives here at the National STD Program. I just wanted to point out that we are compiling a toolkit to improve our gonorrhea and chlamydia screening among our providers. So if some of you have, such as the toolkit, or you have worked on similar projects in your jurisdiction, I would love to get some feedback from you, or copies of your reports and toolkits that you have created. So if you have information to share with us, we would love to get information from you. We are conducting a survey to get feedback from our providers or what components would be really helpful for them in a toolkit, but we'd love to take a look at other examples out there. And then I just wanted to point out that we, for STD Awareness Month, we are hosting a series of webinars this month. Every Thursday, we have one tomorrow at noon Eastern Time to discuss STD Express clinics. So if any of you are interested to participate in our webinar series, please reach out to me. I have my email at the last slide, and I can send you the registration links. And then the last item, we did start recently a National AIN STD Prevention Work Group. to connect key stakeholders and to provide a forum for discussing public health, clinical, community, and other partner perspectives around STD prevention in Indian country. So we've been meeting every quarter. So if you're interested again in joining this work group, we encourage participants from different disciplines to join us. So here's my contact information. You can email me, and we'll be happy to include you in our future meetings. And again, this is the listserv information and the STD program website. And I just wanted to end by thanking all those that contributed in compiling this report, particularly the co-authors from IHS and CDC. So thank you.
Thank you so much, Andrea. I'm going to introduce the next speaker now, which is Amanda Gill. She obtained her Master of Science in Microbiology and Infectious Disease at South Dakota State University in 2006. She began working for the department in 2007 as a disease intervention specialist, providing care and partner services for STD and HIV patients, as well as investigating a wide assortment of communicable diseases. In 2011, Amanda took over as the STD program director. She strives to improve the sexual health of South Dakota's at-risk populations.
Hello, everyone. I hope you're all safe, warm, and wherever you are at. We are currently experiencing an April snowstorm here, but I'm so glad to be with you today, and I want to share some experiences that I've had working with Native communities, with tribes, with Indian Health, and hoping to share some of my experiences and partnerships that I've had. And I think it helps to start looking at public health partnerships on a broad scale and kind of thinking about together, not just one entity as the health department or one entity as IHS or one entity as the tribe and tribal health, but working together, all of us, for some sort of shared endpoint, some goal that we're going to get to. And I guarantee that you will find something, at least one thing, and having that goal. Having a good relationship. Sometimes your interactions and your partnerships may be really intense, and you may be working on an outbreak in a certain community, but above all, having some sort of long-term, ongoing relationship really strengthens that partnership that you have with those entities, keeping up good communication, providing support from the beginning stages all the way through to doing follow-up, building that trust, building that rapport and respect for each other, and having an understanding of who's going to do what and how they're going to do it. And not that we're overstepping anybody's bounds, but that we come together in a nice intermingled way, so that there's not always division or segregation of this agency is going to do this and this agency is going to do that, but how can our work complement each other and come together as one, so that we understand what's going on with the partnership on whatever you're trying to achieve, and how we can best complement each other to get the job done. And that really is a beneficial way to kind of look at it when you're working with some of these partners. So just some different principles to think about when you're looking to partner with other organizations for public health. So in South Dakota, we have several service areas across the state. Our service areas overlaps and jumps up into North Dakota, and that's the Standing Rock. So at our service units, or service areas, we have 12 health service hospitals, I guess I would say. We have a couple tribal clinics operated by Tribal Health. We have a couple urban Indian health center clinics located in Pierre, the center of the state, and then in Sioux Falls, that see not only native community, but anyone actually can go in there. We work really closely and partner with PJ with the Great Plains Tribal Epicenter and the Tribal Chairman's Health Board with data sharing and partnering on outbreaks and resources and different things. And then I think it's important, I guess, to also include and think about any private clinics and other entities on tribal land. So we do have a small handful of private clinics that operate on tribal land, and they see a large number of Native people. So understanding and partnering with those clinics as well is just as important, so that we all have kind of a rounded understanding of what's going on, and that's really been a beneficial partnership for us in looking at it as a whole. Some things that we do really well in South Dakota, and I'm really proud to say, our Department of Health staff, whether it be myself directly managing the STD program, or whether it be the disease intervention specialists that are out in the field and working to get patients tested and treated and identifying their partners and actually doing the work. We have a lot of strengths and partnerships working directly in those tribal communities with folks that are there every single day. Remember that South Dakota is a large state, and there's no possible way that we could be at every single IHS facility or tribal health facility every single day of the week. So we really capitalize on those partnerships. And many times staff are talking to public health nursing staff or IHS clinical staff on a daily basis, at least once, sometimes twice a day, on gaining information and collaborating and trying to figure out how we are serving that patient that may have come up positive for an STD that needs treatment, that needs locating. How can we leverage our resources to make best use of our time and money in all of our institutions to serve that person. And I can honestly say that we are in it to serve that patient and that client. So using public health nursing, using tribal health nursing staff in the couple tribal clinics that we operate at, we've leaned on community health representatives from time to time when we're trying to locate an individual and we're having a hard time finding out where they might be staying, if they're with a relative or with a friend. And so we've got some unique partnerships and a lot of trust we've built over the years working with these agencies and these people. It's really helpful for us when a patient may present into clinic and speak with staff and they're talking about their STD diagnosis, and without the clinic staff says, and we work really closely with the South Dakota Department of Health just to make sure that you're taken care of and your partners are taken care of. And it really builds that bridge right away for us to kind of work together. We use a variety of different tools, whether it's online reporting or whether it's talking directly with people on the phone, or even going up and being at their office and in the community trying to locate individuals. That's something that we do as well. One thing that's been really beneficial is having the clinics help us get patients interviewed for partner services and making sure that the partners are taken care of. So we use a form to assure that the patient got the appropriate treatment, to assure that we have partner information, and then it lets us know, is public health nursing going to take care of that patient and partner? Is the clinic staff going to take care of them? Do they need our help? Maybe if they're off tribal land, do they need our help even if the patient is on tribal land and they're just having trouble getting a hold of them? But we really have this shared responsibility on trying our best to get patients and partners taken care of. And I can share that form if anybody's curious about using it. It's a simple form and you can adapt it to your needs. Over the years, one thing that I can say is being an active partner and an active participant, following through and seeing what you're going to do or what you can provide. We've done trainings, whether it be webinars, whether it be and visiting at the clinic, whether it be bringing in staff from training centers or from CDC, even medications to help treat patients. We've done that. We've done condom distribution. We've done expedited partner therapy packs. We have had monthly calls, providing brochures for them to have in the clinics, attending and partnering at tribal health fairs. There's very few things when I am asked by a tribal health partner or a tribe Indian Health Service that I say no. If it's like it's a barrier or a gap that I can fill, I do try to figure that out creatively and get it approved through my administration so that I can help that community. We've had a variety of different response in regards to STD outbreaks on tribal lands in my work with the health department. And many of the things that we've done over the years are the same, and they follow kind of the same pattern. We don't want to change what's working, I guess. And it's resulted in some changes within the facilities, whether it's increasing the testing for what we call the Big Five: chlamydia, gonorrhea, syphilis, HIV, and Hep C. So really pushing those recommendations and making sure that people are getting their screening done, whether it's looking at data, whether it's policy procedures, and just resources there. In 2012 and 2014, different tribes requested tribal resolutions and assistance from CDC, and they reached out to me and said, could you work with us? And of course my answer was yes. And we had some really strong themes that throughout the years. Again, that kind of team approach, that end goal. We all have an end goal of what we want to get to on sharing the responsibility and understanding the need for that. And I can really say that I've worked with some phenomenal people and very passionate people with I've seen it and private providers that may be providing medical on tribal land. They are seeing risk populations as well when and as needed. We work with the tribal health directors and leaders and clinic administrators from formulating the plan, carrying through the plan, and following up, and I think that's been really good dialogue and open communication, so that's been good as well. We've had different community screening events that we've done and education community events that we've had. We've done a lot of provider education, whether it be webinar or in person. We've had a lot of involvement with analyzing their data in their individual IHS service units on what they've done and who they're screening and how they can improve, and that's been really beneficial. And we even got involved with some public service announcements and involved in the sense that we were supporting the local communities and the public health nurses and CHRs in promoting and doing some PSAs within our community, and that was really beneficial as well. Some lessons to learn from and what we've learned, just knowing the staff in your area, whether it's tribal staff, whether it's clinic staff, whether it's public health nursing, and establishing that relationship, talking about patients, talking about the care of patients. Know your regional epicenter and what they can do for you and how they can share data with tribes. That's something that we work really hard on providing clean data to our tribal epicenter so that they can disseminate that data down a little bit easier than maybe I can. Communication, I think we hear that across the board. Whether it's day-to-day communication on one single patient or whether it's communication on a large event, whether it's an outbreak or some sort of large-scale event. If you have that you can help supplement and provide to them, provide it when you can, extend that hand, be a trusted, active partner. If you say you're going to do something, do that and follow up. I think that's really important to not have any empty, I don't want to say promises, but empty statements. Be patient with the process because sometimes it's going to go really fast and sometimes it's going to go really slow. Be honest with what you want. Be gentle how you say that. Respect culture, respect experience and professionalism. You don't want to go and offend anyone or put anyone off. You just want to be a helping partner, and that's so critical and something that we've done well. If you feel like somebody is making a mistake, you know, in your agency, speak up so that you don't break that relationship with your other partners. And know what's going on, and just be thankful that you have a close working group. And that's all I have now. I love this quote when it comes to doing public health partnering, and I think of it a lot. I actually have it at my office. So if you have any questions, just get a hold of me.
Thank you so much, Amanda. Now I'm going to introduce our final speaker, and then after that we'll have some time for questions. PJ Beaudry is originally from Central Massachusetts and completed his undergraduate degree at Boston University, receiving a BS in Health Sciences before attending Columbia University's Mailman School of Public Health, receiving an MPH with a concentration in Health and Human Rights. He has worked for the Great Plains Tribal Epidemiology Center, housed within the Great Plains Tribal Chairman's Health Board in Rapid City, South Dakota, since 2014, and has served as the center director since August 2015. PJ, over to you.
Thank you so much. I hope you all can hear me okay. I just want to say, first off, that it was an honor to be asked to be part of this webinar and to present alongside Amanda and Andrea and to these great organizations. And I'm really pleased to see also some of my colleagues and partners from the Great Plains area on the webinar today, which is I'm very grateful for, especially given that, as Amanda mentioned, we're a little socked in here. But you know, of course, we don't at the Epicenter can't operate without the support of our partner tribes, and so that definitely is always present for us, and we definitely are honored to serve them and to work with them as partners, as well as with our state departments of health and everything like that. So my name is PJ Beaudry. As was mentioned, I'm the director of the Great Plains Tribal Epidemiology Center. We're based in Rapid City, South Dakota, and at the Great Plains Tribal Chairman's Health Board, and have the honor and privilege of serving the 17 federally recognized tribes in one service area here in the Great Plains region, and I'll kind of get to that in a minute here. But I wanted to, just as a background, kind of start you off with an introduction of the Tribal Epidemiology Centers as a whole, and I have a lot of slides, so I'll work through them as quickly as I can, but this map kind of shows you that obviously the Tribal Epicenter areas overlap with the IHS service areas. And so there are 12 of us across the country, including one, the Urban Indian Health Institute, that is dedicated to serving urban Indian health organizations across the region. And so you can see our mission here and our 7 core functions, which sort of serve to backdrop all of the work that we do and are included in sort of the federal legislation that sort of underpins our work. And so you can see they're basically just sort of broadly based public health activities. And again, I'll kind of go into the basis for those and where they come from, but of course we work to ensure that our work plans are responsive to as many of those core functions as possible in serving our partner tribes, and that's really the key piece of that 7 core functions is in consultation with and on the request of tribes, tribal organizations, and urban Indian organizations. So just a really brief history. You can see the Tribal Epidemiology Center sort of trickling into existence starting in 1996. Our core funding has been from the Indian Health Services Division of Epidemiology and Disease Prevention since that time, and we're pleased to continue to work with them sort of as our foundational funder. And of late, we've sort of had additional funding that's starting to start our funding kind of diversifying a little bit and allowing us to do some additional activities that have been really meaningful. And some other kind of key things to take note of that when the ACA was passed in 2010, it included a permanent reauthorization of the Indian Healthcare Improvement Act, and that included sort of those 7 core functions of the tribal epidemiology centers, and also established tribal epicenters as public health authorities, and I'll talk about that in a minute. And then in 2015 was really when the tribal epicenters kind of formally came together as part of this loose association of the 12 techs under the Tribal Epidemiology Center Consortium. And through that, we've been able to really pursue a lot of collaborative activities, including a network-wide website, a lot more collaborative products, and increased coordination as we continue to grow our infrastructure and capacity and to pursue the work that we're charged with. And so, as I mentioned, through EHICIA in 2010, the techs were established as public health authorities, which is kind of operationalized through the language that you can see on this slide. And of course, that's a really significant development for us in terms of better serving our partner tribes through access to greater access to data under HIPAA and HHS. And through HHS, I should say, and also this mandate that CDC will provide techs with technical assistance. Of course, the application of this public health authority since 2010 has been somewhat challenged by a level of awareness of that authority, interpretations of HIPAA, and need for data sharing agreements, jurisdictional concerns and laws, things like that. So, of course, every tech approaches that a little bit differently, and we all work to kind of address some of those concerns and exercise that authority, which is, for the record, really just intended to complement the public health authority that already is inherent with tribes as sovereign nations. And so, we work alongside them and sort of serve to work together with them in their public health authority status as well. So in terms of GPTEC in particular, you can see that our mission is really obviously to serve the 4-state region of North Dakota, South Dakota, Iowa, Nebraska. Our goals are varied, but again, tied back to those 7 core functions in terms of, providing data, working to improve surveillance, building capacity and collaborations, providing technical assistance, all kinds of things like that. And we offer a variety of different public health services. We're fairly unique within the Great Plains Tribal Chairman's Health Board in that, our work is a lot more cross-cutting of public health activities. And we work to support not just our partner tribes in the Great Plains area, but also our partner programs and within our organization and other tribal health organizations in the region. And so I didn't include any data in my part of the slide, and I really appreciate Andrea covering that topic really well. Suffice it to say that, as you saw, the disparities that exist in the Great Plains area are significant and something that we all work on a day-to-day basis, and really are working to impact, through those collaborations that Amanda mentioned and that I'll talk a little bit about. But I wanted to kind of set the frame for that in the sense that, the challenge that we faced in doing that work is that the development of the U.S. public health system, of course, emphasized growth at the federal level, the state level, and the local level, and really hasn't systematically incorporated tribes, until recently, and even then that's still just starting to grow. And so, this really was one of the sort of reasons why the epicenters kind of came into existence, and one of the things that, again, we work to try to address. And the result of that has really been that reportable disease data is provided to the states, but not necessarily systematically reported back, as has been found in the past. And, that there hasn't been a significant level of collaboration between state health departments and American Indian Alaska Native tribes, at least not operationalized formally. And so I'm actually proud to say that in our region we have some really great state Department of Health folks that work extremely hard to engage our tribes. I'm honored to be presenting alongside Amanda from South Dakota Department of Health especially, has worked extremely hard to address some of these issues, and as well as Josh Clayton, the state epidemiologist, and before him Lon Keitlinger, who have really contributed to trying to address these kind of issues. And of course GPTEC serves in that role as well, to really try to connect some of those existing public health systems with the tribes and tribal health departments, and serve to foster those direct relationships, but also to help connect those partners when that need is there, especially within infectious disease. And so we've pursued a variety of different response activities that I'll cover really quickly. So Amanda mentioned the CDC EpiAids that we were honored to take part in. We particularly related to infectious disease engaged in 2 of those related to gonorrhea and chlamydia and syphilis. And the gonorrhea and chlamydia EpiAid recommendations we're still working on promoting within our region and seeking to implement, which include kind of these that are listed on the screen, and as Amanda mentioned, published in the IHS Provider in December of 2012. We also have published a variety of different video and radio PSAs, posters, all kinds of things like that are available on our website. We've also done a lot of work to try to promote the formation of tribal public health codes and the awareness of why those are important. We held a forum in Rapid City on May 16, 2014, had really extensive participation in that, and some great presenters that covered a lot of different details related to public health codes. And since then we've worked to provide those materials to our partner tribes in seeking to help promote the formation of those public health codes, which unfortunately isn't very widespread both in our area and kind of at the national level. As Amanda mentioned, we've really been working to help bridge that data divide by seeking to increase the availability, dissemination, and use of surveillance data within infectious disease. And so we've benefited greatly from partnerships with folks like Amanda to establish these data pipelines that have generated that raw de-identified data that we can process and put into reports and make available. And then we also are able to offer that data through our data request system, which is located online. We've pursued extensive regional collaborations through our infectious disease task force, monthly regional infectious disease calls that we organized with Great Plains Area IHS, and we just recently lost a great ally at Great Plains Area IHS, Greg Welch, who for years was leading the charge in this effort, and we miss him greatly and are still working on picking up the pieces after his untimely passing. And so those calls are currently on hold, but we're working to try to continue that legacy of his and keep those things rolling. Contributing to regional public health trainings also organized by Greg, participation in state health department meetings and planning groups, and also the promotion of mutual aid agreements and other types of sort of formal partnerships that can be established between tribes and states to help support some of that. I'm also the director of our STI and teen pregnancy prevention initiative, which is funded through FSB's Tribal Prep Initiative. We implement evidence-based teen pregnancy prevention curricula that have been selected by the tribes that we work with. And so we're in our second round of funding and are currently serving 4 tribes on that. And as you can see, the first cycle of that project really demonstrated some really meaningful results, and we're excited to be working with additional tribes in our area to continue the promotion of STI and teen pregnancy prevention practices. And through that, we've also provided an extensive array of resources available on our website. And then just a variety of other projects that are sort of cross-cutting with hepatitis C and HIV that have also been very important to us moving forward, given that, the disparities, within infectious disease really demonstrate the risk that people in our area face with regard to HIV and hepatitis C, and the need for us to be on top of those those types of things as well. So we've pursued a variety of different projects along those lines. So, and I just wanted to kind of leave everyone with this, kind of as Amanda did, with kind of a sort of call to action with regard to contributing to bridging this data divide that we've seen. And this slide is courtesy of my colleagues at the Epicenter, Jennifer Giroux and Dr. Corey Smith. And how we can kind of do that and how the Epicenter is working to do that is contributing to the collection of quality data collaboratively with tribal communities, as well as working with our state partners and our tribal partners, you know, increasing local capacity, pursuing the use of innovative and indigenous methods, promoting communication between different elements of those systems, exploring opportunities to ethically exchange health information across those systems, and identifying and compiling data for use by tribal health in kind of planning, resource allocation, policy development, and those kinds of things. So with that, I will close out. I know they want to make sure that we have time for questions. So I appreciate your attention, and sorry to kind of blast through the slides, but I'm happy to answer any questions, and always available if anyone is interested in reaching out.
Thank you so much, PJ, and thanks to Andria and Amanda for all of your presentations. This is Elizabeth Rubush from ASTO, the Association of State and Territorial Health Officials, and I'll be facilitating our question and answer session. To ask a question, please type a question into your chat box, and I'll get started with a few questions. The first, I think, is for Amanda and Andria. So we heard about collaborations with IHS service units, tribal health clinics, private providers, the tribal epidemiology centers. Aside from those external partnerships, are there any internal partnerships that health officials and STD programs should consider making within their health agency? And I'm thinking specifically of MCH programs or other internal programs, given what we've seen with the disproportionate burden of disease among youth and women.
Yeah, this is Andria. Yeah, we definitely encourage any internal partnerships within state and local health departments. Just an example here at IHS, we are working closely with our Division of Oral Health to promote HPV and oral health as an issue within our communities as well. So just think outside the box, and not just the traditional partnerships. And a lot of us are already partnering with our hepatitis and HIV colleagues, and those relationships are great, but even just think outside the box of other partners like MCH and oral health or other components within your agencies. Some states also have a tribal liaison, so I will ask you to kind of check if your state already has somebody that is already partnering and whose job is to connect and promote partnerships with tribes. Maybe Amanda or PJ have more information around that, but make sure that if you have a tribal liaison at your state, that you're actually communicating with that person as well.
Great, thank you. And another question, given the turnover that we sometimes encounter within our programs at health agencies and also at the health official level, Amanda and PJ, what recommendations do you have for building partnerships for someone who might be new to their position within the health department?
I guess I can speak to that. So I know what we tend to see, of course, is that a lot of the folks that we work with, you know, across a lot of the levels that we work with, people wear many hats as well, you know. So it's almost like building those partnerships, you know, sort of incrementally, and, you know, really kind of meeting people where they're at, I think, as they transition into those roles and things like that, has really been important for us. And just trying to be proactive, you know, it's just keeping those lists up to date, and you know, making sure that when new folks come on board, we try to engage them as soon as possible and kind of you know, bring them into the loop as quickly as we can. And then, you know, like I said, in approaching that relationship, just you know, trying to understand where they're coming from and what their background is and what their responsibilities are, and you know, things like that, so that we can kind of try to meet them where they're at, and not kind of contribute to any sort of overwhelm and things like that as they transition into that role. I think that's been a big thing. But we definitely experienced that at the tribal level, and so it's something that I think we're continuously working on trying to improve in as well. We certainly aren't experts at that, and so we work every day to try to improve the way that we do that kind of engagement.
Great, thank you. And I see that we're at the top of the hour, so I'll turn it back to Leandra to close us out.
Thanks, Elizabeth. Those were really, really great questions that you had for our presenters. I do want to give a special thank you to all three of our presenters and to my co-hosts, my colleagues from ASTO and NACCHO. Thank you all very much. And thanks to all who participated today in the webinar. The contact information for all the presenters are here on the slide. And again, the recording and slides will be made available to those that registered for the webinar, and will also be available on the respective networks and memberships for ASTO, NACCHO, and NCSC. I would remind you to please fill out the webinar evaluation. The link is in the chat box. You'll also be redirected to this link when the webinar closes. This information will be great to help inform future webinars. So with that, thank you again, everyone, and enjoy the rest of your day.
Thanks, everyone.